The Executive Director of the West African Center for Cell Biology of Infectious Pathogens is Professor Odin Awandari. And from the School of Public Health, KNUST, Dr. John Amwesi. We are grateful to have the Provost of the College of Health Sciences, Professor Christian Ejare, in our midst this morning, the Registrar of the College, and all other staff here in our midst. This morning, we'll have 3 presentations from our guest speakers. The first to speak will do so on the topic COVID-19 in Ghana, the role of the private health sector, challenges and lessons learned. Our guest speaker holds a Bachelor of Medicine and Surgery from St. George's Hospital Medical School in London, a diploma in Tropical Medicine and Hygiene from the Liverpool School of Tropical Medicine, and executive certificates from Stanford Seed, Cornell University, Edge Hill University, and London Business School. He's the Managing Director of Nyaho Medical Center, a leading private healthcare provider in Ghana and the first private group medical practice in the country. He has held this position since 2015, and during this time has led the digital transformation of the hospital, integrating services, equipment, and infrastructure through an integrated hospital information system centered around patients and their families. This has enabled the hospital to grow and expand from one central location to multiple sites, improving access to quality healthcare with a personalized approach. He has led the accreditation of the hospital by the Ghana College of Physicians and Surgeons to become the only private hospital in Ghana to train family physicians. He has championed quality and safety in healthcare through launching the Healthcare Forum, an annual forum bringing together key decision makers from the Ministry of Health, the Ghana Health Services, regulatory agencies, private and public hospitals, and wider stakeholders in raising awareness and coordinating efforts in improving patient safety and quality in healthcare settings. In managing the COVID-19 pandemic, our guest speaker led the hospital in instituting systems to identify, isolate, treat patients with the virus by creating effective triaging system, setting up a PCR laboratory to test for COVID-19 and management of patients with COVID-19. He was the president of the Ghana chapter of Stanford Seed Transformation Network from 2016 to 2018, and is a member of the Ghana chapter of Young Presidents Organization YPO. He is an advisory board member for Future of Africa, a charity dedicated to equipping children in street situations to become leaders. Our speaker has won many awards, including the Young Entrepreneur of the Year at the 2016 Ghana Entrepreneurs Awards and All Africa Young Business Leader of the Year 2018 at the 8th edition of the All Africa Business Leaders Awards, organized in partnership with CNBC Africa in Johannesburg, South Africa. Ladies and gentlemen, shall we please applaud our first guest speaker, Dr. Elikem Tamaku.
Good morning, everyone. It's an honor to be here today, and I'm standing on all the protocols of this conference. Thank you for having me, and this is indeed a privilege. For sake of ease, and since I'm more than 2 meters away from you, I'll just remove the mask so that I can speak freely. I believe that this is, I'm very privileged to be talking about this topic because it is very personal to my experience, but also that of the many people that we serve in at Nyaho, our people, but also our community. And so this story is really that of many people. And I'd like to talk to you about the role of the private sector the challenges and the lessons learned. Yahoo's mission and vision is very ambitious. It started from the founder, the late Dr. KNUST-TEK, and that is to be Africa's most trusted name in healthcare. And that trust is the embodiment of people and relationships, not just equipment and infrastructure. So that has been a guiding principle for us as we've grown over the years. The mission has been to transform the lives of patients by surpassing their expectations of healthcare. So we've been very pioneering in that whatever the expectation is, we want to surpass it. And in so doing, inspire others. This can be done in Ghana. In Ghana, as the Black Star, we see that we are very positioned to not just influence in Ghana, but also outside. The organization is 50 years. It was 50 years in 2020. So we had planned to launch our 50th anniversary until COVID then swept up. But it's 50 years of experience. It was founded on the principle of clinical practice. No one doctor, no one individual has all the information. And that's how the organization was founded as the first private group practice in 1970. It has grown. We serve, we have over 100,000 patients in the outpatient. In terms of COVID, we serve over 150 institutions. We have 2 satellite clinics. Before COVID, we were doing also remote clinics, on-site clinics using technology. And then we also have over, these numbers are, the 300 plus actually has changed. And specialists who organize all the different clinical programs, and then 30 medical officers. The organization has grown, and one of the areas of growth is understanding that a healing environment has to be not just about treatment, but as the conditions that support and empower the individual, the patient, in making a decision. So in all our designs, one of the areas is about multi-stakeholder engagement. We have a patient and family advisory council, which we speak to whenever we're looking at different initiatives. And then also comes to our impact. The provision of quality care is our focus, so we're very determined to improve quality of care. We've always put ourselves at a higher standard, so we go with international accreditation and try and get on that journey of improving our services. We also obviously employ. As an employer, we are not getting funding from anywhere. It is solely from our patients and the monies that they give, so we have to be good stewards. But we also want to be good employers. We even use things like paternity leave, things like medical indemnity insurance, things like group life insurance, because ultimately we also believe that our responsibility is to our people. And I'm saying this to help you see the framework from which we can discuss COVID-19. Because understanding where we are working helps in understanding the challenges and the dilemmas private sector players have to deal with. We've been partnering with a district with child vaccination clinics. We have HIV and TB programs with the district. And then, as mentioned already, we are also training, or we are actually working as creating an environment to develop the next generation of leaders in terms of the family medicine residency program. I'm actually here with Dr. Oferiamaka, who's actually leading on that, and we have ambitious plans to not just take people away from the government, which has always been historically the perception of private sector, but it's about how do we impact and how do we grow more people who can actually meet the needs of our country. We launched in 2020, in January, a new intensive care unit, an neonatal ICU and the mother and child. And I'll talk about why that is important. Because when we launched it, we had no idea that COVID-19 would be coming. But we had, at that time, 3 ventilators, which we had for the purpose of intensive care. And as you know, the supply chain issue, that positioned us to actually be involved in the treatment of COVID-19 patients.
and then sustainability is important for us. So these are our main business goals, and these are just examples of our impact in the community. We see ourselves as part of the community makeup. So we organize blood drives, we do breast cancer screening. All of this is done through our Yahuda Foundation, our corporate social responsibility. So let's talk about the COVID-19 dilemma. Should private sector be involved? How should private sector be involved? This was a question that many people were asking when COVID-19 came into the country. And the extent by which private sector is part of decision-making was also a big debate. But for us at NYACO, we had no choice, because we understood that we are part of the healthcare system. And I think that is a call for every private sector player, any faith-based, anyone who's in the healthcare, whether you are public or private, we are all one fraternity, we are all one unit. And the strength of that unit is only as strong as the weakest link. In 2014, when Ebola was ravaging the West African region, the first suspected case showed up on our doors. It was a suspected case. We didn't know it was Ebola, but it was suspected. So basically, all the same protocols needed to be done. But that was a wake-up call for us that, anyone can walk through our doors. How prepared are we? We had to develop relationships with Noguchi, and that had an impact for COVID-19, and I'll explain why. We also had to work with the Ghana Health Service with regards to contact tracing case management, but that in that case was not positive, so all of those systems were not followed in terms of it didn't go on. But it led to the formalization of a public health department and a quality office. Most private organizations, every individual is a cost. So you have to understand that when you look at private sector, the choice to have a public health and a quality office, these are decisions that are based on your values, and that's something that becomes an extra cost, but it's important for your delivery of service, and we saw it as important. Our proximity to the international airport 10 minutes away meant that anything that would be coming into the country potentially be a point of call. And then also our commitment to our staff and our patients, and our values of being in the community. We do not see ourselves as taking. We actually feel that we are there to be a blessing for the community, and that was what drove our decision making. So I talked about the front line. When we saw what was happening around the world, we realized that the front line will only be as strong as its weakest link. If we do not involve every party at the table with equity, what happens is that some places are strong, but others are weak. And when you have an infectious disease, it has no bearing as to who you are, where you are. So if you don't have a strong process at your point of entry, that is going to mean that you have a leakage, and if that goes into the community, your ability to stem the flow is significantly challenged. The global call for a whole of government approach, a whole of society, was led by our government. And I have to commend the decisions that were taken in the beginning. There was quick decision making when the first case came in. But again, I believe that the representation is still going to be a key factor as we move into the future. So policy, whereby private sector comes into play, is really important. So lesson 1, identify risks early, clarify decision-making frameworks, learn and continuously improve. When it comes to identifying risks early, our previous example of Ebola, the suspected case, primed us to realize that this is going to happen again, and if it happens, how prepared are we? So we have always had a stock of PPEs. We've always had our public health scanning the environment. And so in January, when we realized that this was something that was moving beyond China, beyond Europe, we had started with our protocols, and we started triaging at the organization. It's quite an open plan area, so we had to test. We failed a few times where we had false positives. I mean, well, not false positives, they were negative, but we had suspected cases in February. And in those situations, the chain was broken. So we had to quickly figure out, okay, how do we improve our triage so that there's one central entry point. And so this was something that enabled us by the 12th of March. The second recorded case, there were 2 cases on the 12th of March. The second case was actually from Yahoo. It was picked up by our team, and this is why we commend the front line, because whoever you put at your front line should not be the most junior. They should be competent, because they have to make the decision as to whether this person meets the case definition, segmenting them, moving them out, isolating them, and then that's where we actually work with Noguchi to do the testing and got the result. That helped us to contain this situation from spreading into the community and enabled our risk management framework to come to life, because we had already planned what we would have to do if this situation happened. The second lesson is on teamwork and accelerating innovation with partnerships was our key success factor. We have always worked, as I mentioned, as a team, so we work with multiple people. But this came to our favor when the COVID-19 pandemic started to spread. Working collaboratively with stakeholders helped us to identify and understand the competencies. So I've written here, don't let ego get in the way. Sometimes we are blinded to the competencies that are in front of us, and we had a lot of learning ahead of us. We partnered with Clear Space Labs and Serenity Health. So we were able to pivot, and we had a COVID-19 risk assessment chatbot, which had the case definitions embedded into that. So we sent this to our community, so anyone who suspects could easily follow through the technology and find out if they needed to get tested. And this was something that we had were able to do towards April. So almost a month afterwards, we were able to actually quickly pivot. The other benefit was obviously working with the Ghana Health Service. Contact tracing, clinical case management. We had to find a way of coordinating. And I think this was one of the benefits, that there's competence that we have to leverage and we have to build on. So we were able to do a lot with technology, able to pick up patients who needed to be tested and get them to follow the contact tracing through technology. We were also able to, in May 2020, you'll realize that finding a PCR, finding equipment to test for COVID-19 was actually challenging. And this is where partnerships came into play. We would not have been able to set up a PCR lab that had a test kit for COVID-19 if we hadn't already had the partnerships. And so this is where we were able to, we needed to make a decision. Are we going to invest? It was not part of our budget, but are we going to invest in this? We realized that if this comes into our environment, if we cannot pick up a patient, we will not be able to know who is positive and who is not positive, and we won't be able to manage our inpatient. So this was actually important for us to mitigate risk. And this is where we invested. We worked with the government, and in May, we became the first private hospital to be accredited by the government to test for COVID-19. To date, we have tested almost 110,000. It's probably more than that if you include the total positives, but sorry, it's 108,000, but the total positives come to about 7% cumulative over that period of time. But our impact when it comes to the national COVID-19 testing is 7% of all COVID tests came through Yahoo. And that's because the epicenter was Ayawaso West District. And we are located, our main hospital is located in Ayawa, so that's where the spread, the epicenter of the initial spread was happening. So we were positioned to deal with that, and we were very helped by the district in managing the contact tracing. This is our curve in terms of the waves, and you can see it matches the national waves, the first, second, and third wave. But this is the impact of when you start to bring in private sector. So by the third wave, this is using our internal data, you see a depression of the third wave.
And that's really because by that time we had so many, I think Dr. Nsia Asari mentioned that he had over 40 different labs who were testing. And that meant that even though we were still going through a third wave, we now had increased capacity. So this is a good picture which shows that there was an impact of having more testing. So looking at our process, there was online booking. We had to protect our staff. So online booking, we looked at mobile money for payment. We reduced the physical contact, so we had remote teams. And we would actually do a lot of extraction into SORMAS, which was the data management system. And this was done on a daily basis. So private sector should not be a barrier to the government's ability to respond. So everyone has to conform. And I believe that is something that we did as well, and it helped us. Communication, I'm not going to go through too much because I want to get to the meat of the lesson, but this shows again how integrated we were with the Ghana Health system. SORMAS had to be integrated to our system, and we had to look at dedicating our people, our doctors, to look at the first information to positive patients about isolation and how to manage themselves from mild to moderate cases. And so we realized that contact tracing was important, and so through our Nyahoda Foundation, we were able to donate a car to the district for the benefit of contact tracing. And again, it's because of our values, everything I mentioned before, we had a history. It was not the first time we were doing this. So understanding the needs of our community, we're able to respond. So let's talk about capacity constraints because it's affected us in the second wave. I can tell you that I saw people who drove in with oxygen cylinders after having beds, and the reality is that within an hour they died. Those types of stories, unfortunately, happened, and in the private sector, they happened as well, the public. The capacity constraints affect the system, whether it's public or private, and there is, even though private sector play a role, we are still limited. And I think that this is where we have some successes. Obviously, we became also accredited to to test and treat. I want to say this because the treatment, because we had already a system that could support critically ill patients. We could actually support these patients, and this in the beginning was helpful because there were not many ventilators in the country. So for us to dedicate this, it came at a cost. We were able to do this to an extent. We saw about 520 COVID cases with a mortality of 15%. And when it comes to the distribution, again, you see the 3 waves represented here. But this is where the challenges started to show themselves. We have a 10-bedded emergency room. That's the limit. During the second COVID wave, we had to close down our consultations and we had to convert them to overflow because there was no space and people were still coming. Our COVID-19 ward, which had the 3 ventilators, it was an 11-bedded ward which managed moderate to severe cases. But again, when the numbers overwhelmed us, we had to close our medical ward because it was easier to refer non-COVID cases than COVID cases because there were no beds for COVID cases at the time. So we had to shut down, and all non-COVID cases were referred out between January and March. So this shows our occupancy, and it shows the impact of how private sector can help, but you'll see we're having to manage patients in areas that are not meant to be managed, where patients should not be managed, but the impact of the Ghana Infectious Diseases Center opening, which was in February, had an impact on our capacity, which meant that we could now refer patients on to the Ghana Infectious Diseases Center, but even then we were still running close to our occupancy. So there is a need for more infrastructure.
So I'm pleased when the government talks about opening more hospitals. The challenge will always be about the human capital, who's going to manage those hospitals, but it always has an impact on private sector, because private sector is not meant to replace the government, it's meant to complement and support. And I think this was a big lesson for us. So we are very much in support of all the initiatives that happen. This is probably the last lesson I'd like to share, but the most important. So I've saved the best for last. Because at the end of the day, it's human beings who are doing this. Our healthcare professionals have families, themselves have dreams and aspirations. And the lesson was that we need to build psychological safety for our people during times of crisis, and we need to put them to work. Now I'll explain. We were influenced by the American story of Afghanistan. When the American army went into Afghanistan, they initially went with command and control, traditional hierarchy. And they found that all of these militias were getting the best out of them. But this is whereby they had to adapt, because for a rapidly evolving, changing, volatile situation, you need to be able to respond quickly. So this team of teams approach was about decentralizing decision-making and making sure that people are placed to be able to handle and respond quickly to issues that come up. Now, we are a small organization, but we were able to do a lot because of our people. We established wartime meeting rhythms. We already have meeting rhythms, but for wartime, me and my team, the executive team, met every single day from March to November. Every single day, Saturdays and Sundays, for 15 minutes. We actually met to discuss what was a priority, and then they met with their teams. So my team was decentralized. Everyone had a role. Everyone was playing a role where they could make a decision. It was not centralized on me, because if it was me making the decision, then that means that I can only do so much. So I am the rate limiting step for my chemistry days. But in terms of the weekly meetings, we extended that throughout the organization. So every team met. We also established weekly meetings. This was for our extended leadership team, so they could understand the reasoning why we were doing certain things. Our people did not understand, why are we involved in COVID-19? Why should we come to work? What guarantee? You don't have PPE, so why should we come? And this was a challenge, because at the end of the day, they were right. We had a shortage of PPEs, for personal protective equipment, yes. I'm confusing with PPP. But the reason I'm sharing this is because we had to give them an argument for them to buy into. And it was not going to be myself leading that, it was going to be every team leader understanding why we have to engage. We cannot say we cannot engage. We have to engage at the beginning, not when the crisis has erupted. We need to be there. So we also changed our staff DERBA rhythm from quarterly to monthly. We built on our culture of trust by being open and transparent. And that meant that when we didn't have money, because patients were not coming, we had a 70% reduction of our patients. We talked to them about it, and we involved them. We don't have money to pay, but we don't want to let people go. What are we going to do? And voluntarily, this was people's decision, we all agreed to take pay cuts. This was for 3 months, between May, June, and July, from 10% to 25% of our salary, so that people could come. And these are healthcare professionals, with no guarantee that they'd be recognized by, when the government was talking about frontline healthcare workers, there was no guarantee that private sector was involved. So we were definitely going to position and talk and defend for them, but there was no guarantee. But because we were open and transparent, they bought into the values. We published a weekly newsletter. We gave what we could. Free lunch was possible. We ensured that we did our jobs to be good leaders. We got in clinical psychologists. We enforced leave. Every time there was a dip, we told people to go, so that if it was to happen again, they'd be rested. And reward and recognition, when we were able to correct some of our financials, by the end of the year, we actually paid them back. So we have a lot of information that's generated. We do rely on the WHO and the Ghana Health Service, but we do our own. We try and communicate with videos, with different infographics, and that is to build psychological safety. We want to communicate, communicate, communicate. And lastly, when it came to vaccinations, because of our child welfare clinics, because of our relationships with the district in the past, doing vaccinations was not difficult. We had already established the relationships. So when the COVID-19 vaccination came in, we were able to build on those relationships and ensure our people were vaccinated. I think that this, for me, having people who will trust you when times are hard, and they don't have to. In the private sector, you can quit and you can go to another places. Healthcare professionals are in high demand. So, you know, for them to stay with us is a commendation of our people. I want to celebrate our people today, because even though I'm here, I'm representing them. So thank you for your time. I hope this was some interesting insight, and I wish you all the best. Thank you.
Another round of applause for our very first guest speaker, Managing Director of Nyaho Medical Center, Dr. Elikem Tamaklo. Just like we stated, the conference is affording us the opportunity to share our experiences, challenges, the lessons learned, and our preparedness to face any possible future pandemic. We will also use the opportunity to showcase the various researches conducted by our postgraduate students and from other postgraduate students from across the world. I'd like to remind you that CPD points will be allotted based on your full participation in days 1 and 2 of the conference. So please remember to put down your names at the registration centers purposely for CPD points. Our second guest speaker is the founding director of the West African Center for Cell Biology of Infectious Pathogens, WACBIP, and a professor at the Department of Biochemistry, Cell and Molecular Biology at the University of Ghana, Legon, where he was head of department from 2013 to 2017. He holds a master's in biochemistry from the University of Ghana and a PhD in infectious diseases and microbiology from the University of Pittsburgh Graduate School of Public Health, United States of America. He did his postdoctoral training at the Walter Reed Army Institute for Research, USA. In 2014, he led the establishment of WACBIP after winning one of the World Bank's African Center of Excellence grants. Subsequently, WACBIP has won several other big grants, including a Wellcome Trust Deltas grant, which altogether have contributed equipment, infrastructure, and provided fellowships throughout training. His research interest is in molecular and cellular aspects of infectious diseases in Africa, with specialization in the biology of the malaria parasite Plasmodium falciparum and the pathogenesis of its infection in African children. He has over 100 peer-reviewed journal publications in a wide range of journals, including some of the leading infectious diseases and immunology journals. He was a recipient of the Royal Society Pfizer Award for 2015 for achievement in molecular and cellular studies of malaria, the science capacity building in Africa. He is a fellow of the Ghana Academy of Arts and Sciences and the Royal Society of Biology of the UK. In 2019, he was appointed the first global editor for Africa for Experimental Biology and Medicine, the Journal of the Society for Experimental Biology and Medicine. Since the COVID-19 pandemic began, our guest speaker have played a leading role in Ghana's response to by providing research data on seroprevalence and genomic diversity of circulating SARS-CoV-2 viruses. He is currently the chairman of the Governing Council of the CK University of Technology and Applied Sciences in Navrongo, Ghana. This morning, he will be presenting on SARS-CoV-2 variants, implications for control of infection and challenges. Ladies and gentlemen, please welcome the Executive Director of the West African Center for Cell Biology of Infectious Pathogens, Professor Awandare.
Thank you very much. Good morning to everybody. And I would also stand on existing protocols and acknowledge all the distinguished senior colleagues who are gathered here, and fellow faculty members, students, and media, and everybody. So it's a great pleasure to be in this conference, and I'd like to thank my senior, Professor Yao Sakodia, for giving me the opportunity to join you. And Mohammed, who is my brother, who facilitated everything. Cynthia is also a sister, so it's a great working team that put together this conference. So I thank you very much for making the time to come and listen to the talk. So I think that we just had an outstanding talk from my friend Elikem, and I think that what he has presented highlights two things, and I'm going to reinforce some of those. One is that the African continent, you know, the health professionals, as those involved in clinical care as well as the scientists, I think that if we're being honest, I think we have over-delivered. We are given. You know, so I think that as a continent, we ought to be proud of what we did during this pandemic. Like the WHO rep, Dr. Kosolo mentioned that yesterday, everybody expected that, you know, everybody expected the continent to be slammed and damaged and devastated by this pandemic. But it just quite hasn't happened. And that's because God is watching over us, one, but it's also that we've done our part to try to minimize the damage. So it's a combination of the two. So I think that, you know, those of you who like football, there was a time that Leicester City, you know, which had a squad that cost about 1/20th of the big teams like Manchester United, Manchester City, and Chelsea and all that. They won the league. They beat all of them. You know, that's the kind of overperformance I'm talking about. It's based on what you are given. You've delivered more than was expected. So thank you very much. All right. So I know that a lot of people never heard about WAGBIP until COVID struck, which is okay, because after all, WAGBIP was established in anticipation of such situations. And so when the situation came, we had to rise to the challenge and to basically justify our existence. And so that's what we've been trying to do. So I'll tell you a little bit about what we have been doing. I don't know if this works. Good. Okay. So WAGBIP, like was mentioned during the introduction, it's a center that myself and colleagues established at the University of Ghana in 2014. basically based on what we're already doing as a group at the then Department of Biochemistry, where I was the head of department, for universities to establish centers of excellence. So we came together and responded to the call, and we're fortunate enough to be selected to receive the funding. So with that funding, we're able to establish the center, and then the rest is history, as we normally say. In KNUST here, you have a number of those centers, so you're well familiar with the World Bank centers. The first one was RECSEC, which was selected at the same time as we were in 2014. Subsequently, others have come on board. But anyway, so basically, the concept was to draw faculty from across the university with expertise in biomedical research. So it's anchored in the Department of Biochemistry because that's where most of the faculty are from. But we have colleagues from Noguchi who are part of WACBIP, some from the medical school and public health and other parts of the university. And what we have established is a governance system where we operate as a semi-autonomous unit within the College of Basic and Applied Sciences. What does this mean? It simply means that the university doesn't give us money to run. We're not in the university's budget. We have to raise our own money and pay everything that we do. In exchange, we have more freedom to be more efficient because, as you know, university bureaucracy is not the best for doing science. So it's a trade-off. We get more flexibility in how we manage our resources, but then we have to raise our own resources. So the gray hair you see is because I have to raise resources to pay staff and to run equipment and to give students scholarships. So that's the price of the gray hair. Anyway, so like we started with support, but shortly after that, the Wellcome Trust also initiated another capacity building program, and we jumped on that as well, and we were lucky enough to be successful there. We got another 7.5 million or so, and that really gave us the opportunity to consolidate what we're doing. So the dream of all of us who started this was to establish the center as a hub for biomedical research and leading the development of new leaders right here on the continent within the African context. And this is because many of us had trained abroad and we had come back, and we came to a department that, basically there was nothing, but we wanted to be here. So we were dreaming of creating an environment where we could do the science that we're doing when we're overseas, and then giving the opportunity for others to get PhDs and masters in that environment. And so that was the dream. So I'm happy to say that we have been greatly supported. And so we've made a lot of progress in achieving that dream. So in addition to the World Bank, because we started off and started to deliver results very quickly, we have a lot of funders who came on board and supported us. So we've been able to provide a full training pipeline from graduate internships to masters to PhD, early postdoc, and then to career development fellowship. So all these are funded by grants. And so in our system, it's a competitive system. People who come for graduate internships or national service, they compete with others from all over the continent to get master's slots. The master's people compete with others to get PhD slots. PhD people, when they finish, compete with others to get postdoctoral slots. And the whole point is to identify the best young scientists and give them an opportunity to develop. So since we started, we've now given fellowships to 271 scientists from across the continent. And you see the dots on the map showing where all our trainees have come from. Obviously, the vast majority are from Ghana, but you see that there's a presence in the sub-region and spreading all the way across sub-Saharan Africa. So this is what we've done. In addition, we've produced many publications in peer-reviewed journals. Our research portfolio, we initially started as an infectious disease center, but responding to the position of disease in Africa, where non-communicable diseases have become a major part of our health burden. We've expanded to non-communicable as well. And that's through the genetic work that we do. Because of the human genetics component that we do, we're able to dip into non-communicable disease research. So what binds all our work together in a diverse research portfolio is that we use molecular and cellular approaches. So if you look at all the stuff we do, we are not just doing epidemiology and counting people and testing positive or negative. We want to go deeper. And that's just to create our own niche, and that's what we do. So COVID-19, we are not a testing site. We test for research, but we're not a testing site. We're not providing testing services. Instead, we're doing genome sequencing, okay, and doing seroprevalence studies, looking at antibody responses. So that's the approach we take, because we think that there's a need for that. There's a need for the basic science research to be developed on the continent. So one of the things we've done with the resources that we had is to invest in the research environment. My motto always is that if you're a center of excellence, you must look like one. Somebody walks into your building, it should look like a center of excellence. That's the first thing. Elkem talked about the psychological aspect. When you have young people, you want to train them, they must have confidence in the environment in which they work, because they want to go to Oxford, they want to go to Harvard, but you have to provide an environment that looks like Oxford and Harvard. So now our students go to Oxford and Harvard for short visits, and they come back and they are not in awe, because it's not very different from what is around here. So they are not desperate to go to Oxford and Harvard. So it's very important to create that environment that allows high quality science to be done. So what we did was to invest a lot of the resources in high-end equipment, and then we organized this into what we call technology platforms. So one of that is the next generation sequencing, which I'll talk about. But we also have flow cytometry. We have one of the most advanced flow cytometers in West Africa. We have confocal microscopy and a lot of fluorescent microscopy, and that is also one of our technology platforms. We have high performance computing. We invested a lot of money to build capacity for computing. If those who know a lot about data, genome data is in terabytes. So if you don't have high performance computing, your regular computer will crash if you try to analyze genomes on it. So you have to build high performance computing capacity, which is a cluster that you put together that people can access and use. So we built that, which is one of our technology platforms. There's protein expression. One of the things that we had to do is to be able to express proteins in high quality. These are things that would be useful when we start to think about making local vaccines and things like that. So we have a unit that can make protein expression, can edit genes, and manipulate genes and make different types of proteins. So those are some of the platforms we set up. So then, so COVID came. So we were there minding our business, training people, and doing research into everything else. And COVID came, and then, like I mentioned, we had to step up. So we had to basically reorganize and redirect both our human, physical, and material resources to help with the pandemic. So we do not take any money from the Ghana Health Service to do what we do for them. We do it because we were lucky enough to already have resources to be doing similar things for other diseases, so we could redirect those resources to COVID-19. So we do a whole range of research investigations, ranging from immunology to the genome sequencing that everybody has heard about. We do seroprevalence studies where we look at exposure to COVID-19. There was a great talk yesterday from by Anthony on seroprevalence. We do those type of work. We are developing diagnostics. Today I'm not going to have time to talk about that, but we have some smart young people who are developing innovative ways of diagnosing diseases that are cheap and can be used at point of care. So those things are ongoing. And then a whole lot of other, molecular and cellular stuff. So you all heard about the first time we were able to sequence the SARS-CoV-2. It took us about 3 weeks to figure this out. And the interesting thing is that the reagents we used to sequence the first batch of samples, actually those reagents, we got them through our collaborators for sequencing malaria parasites. So at the time, we were trying to buy reagents to do sequencing for malaria. And we were having a lot of difficulties with procurement and all that, and it was taking a long time. So I called up my collaborator in Oxford, and he says, oh, we can order that for you, So he says that, give me the items, order it, I'll pay for it, and then you refund me later, okay? So this is how science should work. In Ghana, if I did that, they will take me to Public Accounts Committee for corruption, for just ordering reagents. But this is how science works. If all of you have worked, or many of you have worked outside the country. When you are doing science in the US and other places, you just sit and you go online, you order stuff, the next day they are at your door. It's nothing about procurement authority giving you approval for sole sourcing and all these things. That take 3 months before you can place the order. And then it takes 6 months for the order to come. You can't be competitive that way. So anyway, phone call, reagents delivered, $40,000 worth of reagents. And whilst we were planning to do our sequencing, COVID struck, and then we said, we have to quickly try to see if we can sequence these samples. So we redirected the resources. All the people we had trained to be doing sequencing for malaria, we put them on task, And that's how basically we sequenced the first set. So this was subsequently published at the end of last year. In addition, I'm sure some of you have seen this paper. There's a landmark paper from about 300 authors from across the continent. This is very significant because it shows how COVID has led Africa to mobilize our scientific resources. And this is a great effort by scientists contributing genome data from more than 40 countries and putting that together to publish a paper in Science, and the quality of science as a journal. This paper actually includes data from not only WACB, but KCCR and UHAS as well. So what have we been doing in terms of sequencing? So we have been doing sequencing of any samples that come our way. So we've had samples from across the country. I've shown here how many have come from each region, and you see that it's entirely random. There's no scientific formula for these numbers, so this is just what we got. And this is because we use a purely opportunistic approach. We do not have the health research infrastructure in place to do this kind of sampling in a very logical way. So what we've done is that we ask the Ghana, just send us the samples, we'll sequence them, we'll give you the data, we'll tell you what variants you have and all that. And some have responded. So I have here a list of several testing centers across the country who have generously given us samples. If you call us and say, you have samples for us, we'll arrange and come and pick them up. And we'll sequence them, we'll send you the data. So we'll share the data with you so you can do whatever you want to do. The KCCR has contributed some samples. We're looking forward to Yahoo, partnering with us. Because one of the challenges we have is that we don't have a lot of clinical data to go with the sequencing, because our doctors, understandably, are more interested in taking care of patients than, putting data together that would help us try to understand the relationship between all these variants and clinical symptoms. But that's something we hope we can fix going forward. But anyway, so we want to acknowledge all these testing labs that have contributed samples. So here is an overall summary of the sequencing we've done since July. So these exclude the initial sequencing that we did. So the initial sequencing we did on Illumina, but subsequently we switched to MinION sequencing. So these are the MinION sequencing data. So far we've done over 1,300. In fact, the majority of genome sequencing in Ghana has been done by us. So if you go to the GSAID database, where all the sequences are deposited, probably 70 to 80% of the sequences in Ghana are from WACBIP. So anyway, this is a summary of all the variants that we've ever detected since July, when we started doing the MinION sequencing. And you'd see that the variants of concern are there, and they're dominant, and we'll talk a little bit more about that later. But one of the things to note is that you see the Delta Plus. So over the last few weeks, what has happened is that the Delta group became so heterogeneous that they have decided to sub-classify them. So the Delta Plus has become even more prominent now, because they've reclassified some of what we used to call Delta into Delta Plus. And so Delta Plus has become a big group that they call AY. So you have AY1 up to AY10. And so if you put those together, they are the most dominant group now. So you see the breakdown there. Like I mentioned, our pandemic has been driven mostly by the variants of concern. So before the pandemic hit, we had mostly B1 as the strain that we had here. But then anytime the variants of concern came, they outcompeted the variants, and then they took over. And then subsequently, a more superior one will come and take over. So this is the breakdown of the variants of concern that we have detected in the country over the period of about 1 year of sequencing. One of the interesting things that this sequencing has shown is that for Ghana, it appears that all the variants of concern normally come from travelers. And so when the government smartly started giving us samples from the airport to sequence, you could really just track whenever we detected variants in travelers. In a matter of a week or two, you'll find it in the local, the community transmissions. It was just very clear that it was the travelers that were bringing this. So you'd see that among the travelers that we've sequenced, you see that a lot of the variants that we've detected in travelers are actually the variants of concern. And if I show you the timeline, you see that basically the travelers bring these things. And the other interesting thing we found was that the variants, they come from all over the so-called UK variant, the alpha variant. People were thinking, oh, it's coming from the UK. Actually, a lot of the samples that we found these variants in first came from around us, So people coming from neighboring countries, people coming from Tanzania and Ethiopia and others, carrying variants of concern, So basically, this was very interesting because it showed that, one, these variants were already all over the place before we detected them here. They're already all across the continent. But because sequencing is not going on in many countries, especially our neighboring countries, so they were not reported, but they were already there. So people just brought them in from those countries. And other thing that is interesting is that, and also supports the fact that these are normally imported. If you look at the trends or the waves, you see that since the second wave, which is when variants started to become the major driver, you see that the pandemic numbers in Africa, have lagged behind the global numbers. And even further, Ghana's numbers have lagged a little behind the rest of Africa. And I think that this is because the variants come from other parts of the world, not Africa. So we always get them a few weeks or months later. And for the case of Ghana, I think that we ought to give some credit. I think that the airport testing, testing on arrival, actually made a difference in slowing down the entry of variants. So if you look at Ghana juxtaposed on the rest of Africa, you see that there's a lag. And we also, when the third wave came, most parts of Africa were already in the third wave and had Delta, and we were still coasting. We were still enjoying our lives here. So I think that all the criticism we have given the government for the airport testing and the contract and all that, but the policy itself, I think it has been good, it has been effective. Now, it means that it's not 100% tight, because eventually the variants come in and we get a wave, but it is obvious that it helps slow down the entry of variants, and that is something that those of us who are critical of government, sometimes we have to acknowledge that some things have worked well. So this is just more on the community transmission, just showing it by region. So this is samples we did in 2020. So in 2020, we had samples from only about regions. And you see that certain variant dominated in certain regions. I think that in 2020, the most common variant was the B.1.1, which was all over the place. And you can see that it dominated in all the regions. But when we come to 2021, when the variants started coming, or the variants of concern started coming, we found that it was quite interesting. Normally, the major variants of concern that cause a lot of global disease or the global cases, they normally are dominant in Accra and Kumasi and the big cities. And we found that places like Tamale and other places actually had different variants that were dominating there. And we are thinking that it's possible that some of those variants came in through the illegal land borders. They're not through the Kotoka airport. Because we had this variant called ETA. For a long time, we were monitoring in Tamale. It was mostly in the northern region before it came to Accra, and then it started picking up in Accra. But for a long time, it was just in the northern region, in Tamale. Then 827, or 827. We also found that it was also localized in the northern region for a while before it spread. And so we suspect that these were probably cases that people who drove from neighboring countries and found their way into northern Ghana, they brought these variants. So they started to spread there before they spread to the rest of the country. Yeah. Now, this is just the same data shown month by month since July 2020. And it just shows you how the variants have basically changed, the evolution over time, that variants come and others come and displace them and they go. So you see the color scheme has changed over time. I'll show you a line graph of some of this that is clearer. Globally, we can see that now Delta and Delta Plus together as a group, they are dominating everywhere. You can see this light blue or light color is dominating globally. Very consistent with what we're seeing. If you look at some of the, and it's now almost at 100% in terms of variants in most of the countries. In Ghana, this is a little refined of the data I've shown you, where we pick out the variants that have been interesting for us. I don't want to say variants of concern because some of them have not been designated as such, but we think that they are very interesting. One of them is this B.1.1.3.1.8, which was first reported in Mauritius. If you look at the curve here, that's the one in blue, and there was a period where it actually took over, and you would see that period was just before Delta came. So, when we started, we had different variants, here, we had the ETA, as I mentioned, which was something that seemed to be dominant in the north before coming over to Accra. And then Alpha came, and Alpha took over. Alpha is here. So Alpha came in January 2021, actually in December, but we started detecting the community in January. So you see that it came, it had a little bit of a competition with the ETA, and then it crashed when this 318 came into the picture. So you see the 318 basically crashed both the Alpha and the ETA and took over for a while across the country, and that we found to be very interesting. And then Delta and Delta Plus came, and basically they have been the most dominant variant we've ever seen. Somebody was joking that maybe this will be the end of COVID, because if there's no variant superior to Delta to take over from Delta, when Delta crashes, then the pandemic will be over. So we hope that's what will happen. Some of these mysterious pandemics can end that way. They just crash on their own weight. Because, based on the data we saw yesterday and data we are doing, in most places, 40 to 60% of us in Ghana have already been exposed. So this crashing of variants you see is likely because so many people are exposed that we have some kind of natural herd immunity, if you want to call it that way. And so the variants crash by themselves. So if that happens to Delta, if enough of us are exposed to Delta, and survive, Delta can crash on its own. And if there's no superior variant that can escape the immune response that Delta has generated, then those variants will not be able to thrive. So let's hope that that's what happens, that this will be the end. But you can see that for now, Delta and Delta variants are, unprecedentedly dominant in terms of the variants. Just a little bit of flavor for those who like the molecular stuff. So we drilled down a little further to look at what mutations are in the variants that we have in Ghana. So it was interesting. We found that there's quite a lot of heterogeneity even among the variants. So you have Alpha variant, but within the Alpha you have some that have 2 additional mutations, 3 additional mutations, 20 additional mutations, 45 additional mutations that other Alphas do not have. Okay, and that is very interesting. So you see here that we've shown the mutations in with these dots. So you see that some of the variants, there's quite a lot of diversity when you see that broad spread of different mutations. And this is very interesting because this is how wild variants can come about. Because all it takes is that these mutations that are occurring, if 1 or 2 occur in very critical, parts of the spike protein, then you can have the new variant escaping the immune response that is generated by even Delta. And then you have a new problem on our hands. So it's something that we have to be mindful of, that there's a lot of ongoing mutation in the variants. The other thing that we found to be interesting is that this 318, which we are very interested in, is actually very close to the Alpha. And I think that's probably one of the reasons why it was able to quickly take over from Alpha, because it's close to the Alpha, but it has additional mutations that allowed it to be more superior to the Alpha, and then it took over from Alpha. This is another way of looking at it, where we show the variance, and you see this checkered board telling you all the variation you see in the different variants in the country, and that's a lot of variation. Everywhere you see the purple, that means there's a different mutation there, and that is telling us that we have to be careful. All right, so to summarize, since we've been doing this since last year, we've identified about 51 unique variants. In fact, the majority of them are in very low numbers, but the variants of concern are the ones that dominate. So about 6 variants of concern that we've detected, and they constitute about 60% of the genomes that we've sequenced. Like I mentioned, local transmission was dominated by the B11 until the variants of concern came. and then they took turns to dominate the transmission. I've also said that there's a lot of ongoing mutation, and so if we don't get vaccines deployed in time to slow down the transmission, there's always a chance, we hope it doesn't happen, that there will be 1 or 2 bad mutations that would occur on top of the Delta and make it into a monster variant. So we have to be very mindful of that. All right, so just before I take my seat, I just wanted to mention that we are getting support from funders to scale up what we're doing to the sub-region. So we currently have a grant from the Rockefeller Foundation to extend sequencing to Burkina Faso and Nigeria. We're getting some funding from Wellcome to set up 7 labs in Western and Central Africa to be able to sequence, to do green-iron sequencing. So they're giving us funds to buy equipment for them and set them up to be able to do green-iron sequencing. And so that provides an opportunity for a lot of training, and I think Ghana would get to enjoy some of that training. So we're able to set up a few more sequencing hubs, hopefully in some of the big cities in Ghana. We are also getting support from RD to do similar things, working with the Francophone countries to try to support them to stand up their own sequencing laboratories. The other thing we are getting support for is from ARUA. ARUA is the African Research Universities Alliance, which is an organization that is being led by one of our former vice chancellors, Professor Ernest Aite. And they've been trying to mobilize resources to support science capacity building on the continent. And last year, they started an initiative to, on the back of COVID-19 and the pandemic that ensued, to set up vaccine development hubs. One in Southern Africa, one in Eastern Africa, and then one in Western Africa. And we were selected to host the Western Africa one. So we're getting some support to organize scientists who are interested in vaccine development in Western Africa so that we can work together and build capacity for vaccine development. All right. I want to plug this journal that I was appointed as the first global editor for Africa. So this is the journal of the American Society for Experimental Biology and Medicine. And it's a very old journal. It has an impact factor of about 3. And a few years ago, they strategically decided they wanted to reach out to Africa because they were not getting a lot of presence in Africa and a lot of publication from Africa. So they wanted to identify, someone in Africa who can, give them some credibility on the continent to attract papers from the continent. So they came over and inaugurated their office at WACBIB. And so since then, we've been helping to process papers submitted across the continent. So I think a lot of you have work that will be relevant. It's a broad scope, but a lot of the health science work that we do and others would fit there. So take a look and consider publishing there. All right, I want to acknowledge our team. We have a huge team from field work to all the way to bioinformatics, and they work day and night, risking their lives so that I can come and talk to you and sound good. So I'm very grateful to them. I want to acknowledge all our funders. We have so many people, so many funders who chip in for us to keep the lights on and to keep our students working. So we thank all of them. And I thank you very much for your attention.
A better applause to Professor Gordon Awandari. As he presented, I realized that we were moving gradually from the stratosphere into the exosphere of the scientific conference. Yeah, because at the stage where he was presenting on the variants and the genome sequencing, I realized the kind of faces, but I think that was, or that's online. This reminds me of our experience at the undergraduate level. You know, in our time, those of us who read biology were those who were given the biology-friendly programs here in KNUST, and then those who read ADMAS, what we call elective maths now, went into engineering. So what happened? Our first semester, we were told that there is a course called post-SS maths that we have to undertake. And these are a group of biology students from senior high school who have nothing to do with that maths. And we are having to take post-SS maths. So PE will be teaching and continually asking us if we understand. We said, no, we don't understand because we did nothing at maths. We don't understand. Say, well, won't you ask how should be? So when we go to genome sequencing, for those here, you are scientists, so that's it, we are okay. But those watching, won't you ask how you should be at that level? I would want to acknowledge some distinguished personalities who have joined us for today's program. And I'd like to acknowledge the National Medicine Selection Committee tasked by the Minister of Health to develop standard treatment guidelines and essential medicines list for COVID-19 management. The committee, chaired by Professor Francis Ofe, involves Professor Kwame Ohene Boabeng from the College of Health Sciences, KNUST, Mrs. Mimi Delis Dakon, CEO FDA, who was with us yesterday, Mr. Mark Jradosi, and the AMR platform members, including Dr. Martha Jansa Lutrot, Akusia Nyonaku of the Ghana AIDS Commission, amongst others. We thank you for coming around. We also want to acknowledge the principal of College of Health Sciences, Yendi, Mr. Raymond Kuntu, and his vice principal, Mr. Hussein Abdul Karim. Thank you very much for coming. We are excited when we get people coming from far to be part of such programs. Ready to listen to our third speaker today is a senior lecturer at the School of Public Health and the head of Department of Community Health at the School of Medicine and Dentistry, KNUST. He is also a group leader of the Global Health and Infectious Disease Research Group at the Kumasi Center for Collaborative Research in Tropical Medicine, KCCR, which hosts the Secretariat of the African Research Network for Neglected Tropical Diseases, which he spearheads. Our speaker trained as a physician at KNUST and later graduated from the University of Minnesota School of Public Health, USA, with postgraduate degrees terminating in a PhD in Public Health Research and Policy. He also served as the head of Research and Development Unit at the Konfanochi Teaching Hospital, Kumasi, from 2007 to 2010. He has consulted for several international organizations and is passionate about research that focuses on improving health systems, services, and outcomes, including policy analysis, using both primary and secondary data in low and middle income countries. His research currently involves field epidemiologic studies on malaria, snake bites, and other neglected tropical diseases. Our speaker serves as an executive committee member of the African Coalition for Epidemic Research, Response and Training, ALERT.
The dean is in the house, Newton. So Newton is here, and I believe also the dean of SMD is here, and all other deans. Greetings, and to all senior colleagues. I also want to particularly mention the director of KCCR, if he's here, Professor Phillips. I don't think he's here right now. And ultimately my team at KCCR, Global Health and Infectious Disease, research group, really hardworking team. You'll be seeing more of them around. So this morning I'm going to speak on COVID-19, an urgent call for a new kind. COVID-19, an urgent call for a new kind of health professional. Now, this title is only a mask for what I really want to talk about. And so the content you'll see for yourself. I've really enjoyed the talks by the previous speakers. And I really celebrate all of you, especially yesterday and today. Really exciting talks today from ULIChem to see all that's happening at Yahoo. I had no idea that you guys were so advanced. Perhaps maybe because I can't afford to come to Yahoo. Maybe I didn't know. Gotcha. And then also from Gordon, really amazing stuff you're doing there at Wagbe. But I think we've only been seeing the tip of the iceberg or the ears of the hippo, but you should show more of what you're doing because this is really amazing. Knowing what's going on in the sub-region, it's really clear that we are several steps ahead, and I really wish you even greater success moving forward. So I'm calling you kind of health professional, and I'll explain why I'm making this call. But before then, I'd like to invite you to a little exercise. And for that, I'm going to switch quickly to take out your mobile phone, if you could, or any device, of course, and go to the website menti.com, MENTI.com, and please enter the code 36127014. So if you go to MENTI.com, when you go there, just enter the code you see on the screen, 36127014. Just want to conduct a little exercise. It will be very brief, and then we'll get to the meat of the matter. Okay, so people have started voting already. One may think it's a moot question, but there's a reason why I'm asking. So I didn't show the numbers, I only showed the percentages. All right, at this rate, I think that we have enough. Just move on to the next one. All right, so the next question I'll switch to is, people are still voting, so I have to find a way of moving on. We have about 51 people voting now. All right, next question. Have you received any dose of a COVID-19 vaccine? Any dose at all? And if you watch the count at the bottom, that's the number of people who have voted so far. So 53 have voted. Have you received any dose of a COVID-19 vaccine? We hit about 65, I'll move on. Are you surprised? I'm not. If we can hit about 80, I'll move on. Okay, we've hit 80, I'll move on. So you can see for yourself. I don't know if you're surprised or not, but it is what it is. And it's even changing further. The last question, if you have received, so if you did not receive, you've not received a dose yet, this question would not apply to you. But if you have received a dose, please share with us. And this is completely anonymous. I can never tell, even at the back end, who said what. Right? So do feel free. So we've hit 64 climbing on. If we can get, well, we had 80 plus 86 for the other, and not everyone had received a dose, so I think we're almost at a healthy representation. So you can see that even among those who have received one dose, at least a dose of some sort, initially there was skepticism. I had a friend who said, they'll take anything, just jab me with anything. I'll just take it. And others who wanted to wait until they observed if some of us dropped dead, then they'll decide. But anyway, so much for this exercise. Now the point I'm driving at is this. The whole issue of vaccination is a critical part of our discussion around trying to find a solution to COVID. I really enjoyed what Gordon spoke about, and he talked about the possible crash of variants. Yes, and I saw somebody taking a note that they're adding it to their prayer topics. Pray for a crash of variants. And then when they lift their prayer topic, shall we pray for crash, 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 crash. I guess that won't be a bad prayer topic at all. But the truth remains that being unvaccinated really puts everyone in a bad position. And people are hesitant to be vaccinated for different reasons. Some don't believe in the vaccine, but others do believe in it, but are still concerned about getting vaccinated for various reasons. And we recently published a paper looking at vaccine hesitancy, and we're looking at doing a rerun of this because I think that the stakes have changed rapidly, because this was just before the third wave. And if what we saw during the third wave, which sort of coincided with the arrival of a new consignment of vaccines, what we saw, people queuing up to be vaccinated, were really encouraging, then maybe things have changed. There's a new vaccination drive ongoing. I've not seen those kind of queues that we saw during the third wave, but but the reason I conducted that exercise was just to point out a few things, just showing how, and these numbers are a bit hard to see, I realize the screen is not very large, but there is a huge variation in the way Ghanaians respond to a vaccine. It varies by age grouping, varies by educational status in particular, varies by even sex, right? And also the source of information which they often frequent. And understanding these dynamics can be really helpful in strategizing and planning towards how we go about addressing vaccine hesitancy. Just a few of these results I want to share with you. And again, the screen is rather small, so perhaps not very helpful, but maybe I'll just try and see if I can blow up a small section of it, and you can see the age groupings and the variations in responses as to whether they were not likely to vaccinate, not decided, or likely. So those are the colors. And so you can juxtapose this against the age groups here. And then here is just by sex, male, female, and this is by level of education. J is secondary, tertiary, and postgraduate. So you can see those different distributions. And some of these findings were statistically significant. This is also reasons why people were undecided about vaccinating. And the most prevalent response was, I am not well informed about the possible effects of the vaccine. Which tells you that this whole talk around information, let's put information out there, is not just a cliche, it really is critical. And we can see this even from the distribution in here of people who have not even received a single dose of the vaccine. And this is among a sample of everyone has a tertiary degree. So that's we all process things differently and make decisions differently. We need to respect that, but also try to understand that so that we can harness the best ways of getting people to do what we think is most helpful for everyone, even if they think that it's not very helpful for their own selves. This is just another distribution of reasons for not wanting to take the vaccine at all. And majority was saying that they're not sure if it's clinically safe, which is another reason why I'd love to repeat the survey, because now many people in Ghana have been vaccinated, people haven't dropped down dead. So maybe that perception of safety would have changed, and that could really influence how we go about doing things. I just put this slide here to show that how we go about pushing information is very critical, because we have a fairly high level of internet penetration in Ghana, but not as high as ordinary mobile penetration, which is way over 100%. But just understanding this and also seeing the urban-rural variation, which is also moderated by educational level, could help us in the way we craft our intervention tactics, right, and how we go about doing things. So that's just, for starters. I want to move to the real topic. Right? As I said, the other one was for the brochure, so I don't get into trouble. But this is the real thing. Why lucky? And I want to argue that in Ghana we have been fairly lucky. Yesterday, Dr. Kasolo pointed out a number of very good things that we did in Africa through WHO, Africa CDC, and others. And today Gordon has also pointed out a bunch of things we've done right. Elikam also does the same thing. And I do agree, and I'll be touching on some of these as well, that we have done a lot of things right. We've done many, many great things. But I'm gravitating to the conclusion that while we did all these great things, ultimately, we were lucky. And I'll try and press on this point, not necessarily to convince you, but just share my thoughts with you. So we're living in unprecedented times, times that we've never seen before. 4.6 million people have died to COVID. If anyone had suggested that we would have even 1 million people dying globally within the space of about a year, pre-COVID, everyone would have thought this is simply not possible in this modern world of ours. But here we are, 4.6 and climbing, and there's several deaths from COVID a day. In the UK, they're recording upwards of 130, 150 every day to date. Yesterday was 130 something, 136 also. So people are still dying every day, including here in Ghana. People are still dying every day. It's just that it's no longer big news. So this is serious. We're living under the unprecedented effects of climate change. Parts of Africa like Madagascar, and particularly in Mozambique, the floods that they had last 2 years, were something that we've never seen before. Hard to explain, but we can put it on the doorstep of climate change. The floods we've seen in Europe, the fires in North America, in Siberia, and other parts of the world, even in North Africa and Tunisia. These are things we've never seen before, not to speak of the usual fires in the US and in Oceania, which are usual but have been at an unprecedented level. There's also the unprecedented leaps and bounds that we've made in technology and the amazing things that we can do with artificial intelligence. And there is a burgeoning artificial intelligence movement here in Ghana. Artificial intelligence is being used in every sphere, including health, being used for warfare, and with all these tactical robots that are being deployed to do warfare, only God knows what might come next, but we're living in unprecedented times. But there have also been unprecedented challenges that COVID-19 has layered upon all these unprecedented times, with reduced global production and reduced economic growth. Ghana's economy grew very marginally in 2020. Largely we're lucky. The last quarter is what just helped us to boost up a little bit. Economies have seen recessions, and things have really taken a dip globally. Many of us have suffered in different ways. Tourism has been changed forever. So many things. I didn't need to go through all these. And so I think that the pandemic is really a time for what I call the big reset, the big global reset. And whether you like it or not, the reset button has been pushed, and the changes are taking place, sometimes quickly, sometimes slowly, but there are changing times and things are changing very quickly. But these also present opportunities that we might have never thought of before, but now have presented themselves. And I've tried to line up some of these opportunities against the challenges that I had earlier on listed as coming out of COVID. And I think if we're able to look at these carefully and inform ourselves as to what we must do to take advantage of these challenges, it would go a long way. And thankfully, Ghana seems to be doing just this. I always say we could do better. There's always room for improvement, always. And that's the way we should be looking at things. It is a dangerous thing to pat yourself on the back, rest on your oars, and think you made it. If you don't believe that, you can look at India, look at Brazil, and you see the story for yourself. I also see the pandemic as a big leveler. And pandemics are like this. They are big levelers. Let's look at Ebola. With Ebola, it was well, a big leveler in its own self, but not like COVID, because unlike Ebola, this time we are all at risk, equally at risk, all right? And we're all seeking the same kinds of remedies. Everyone is looking for the same solutions. Everyone is on the same page. Aside that also, there is an equally limited knowledge, or there was an equally limited knowledge. When this pandemic started, everyone was at a loss. We got to know it was some COVID virus, well, not COVID virus, it was SARS virus, and I can't even remember the name it was called at first, but I remember I happened to have been at that meeting in Geneva when it was christened COVID-19. And those were really strange times when we met in that room to discuss and give it that name, COVID-19. Equally limited knowledge. Well, now the knowledge is being spread around. Now we can do sequencing in Ghana at least, but many places were in the dark. There's also been massive blunders that have occurred all over the world. Everyone has made mistakes. Think about the ultra-hard lockdowns in some countries that resulted in, psychological trauma to many people. You can think about zero COVID policies in some countries, which they had to turn around and say, look, this just doesn't make sense because we're literally hurting ourselves. The medicine is becoming worse off than the ailment itself. Think about the free-for-all in the UK, where they decided to go for herd immunity. One may think it was a foolish decision. I don't think so. It was just a scientific decision that turned out to be wrong. It's a hypothesis that they tested and found to be wrong. Also, the premature celebration of success. Think about Brazil, think about China. It's been a big leveler, unlike Ebola, because with Ebola, things were slightly different. But I want to also speak about the globalization of the disease. And I make reference to the globalization paradox. And this paradox plays out in different ways. One of the first ways it plays out is, unlike Ebola, well, Ebola allowed for rapid response to suffering nations. So Guinea, Liberia, Sierra Leone, we saw how countries rushed to support. Ghana sent doctors to Sierra Leone and to Liberia. One was touting that as an example of how, in a pandemic, the world should rally. But look at what happened with COVID. It was each country to themselves. The rich sorting themselves out and caring very little. Perhaps it makes me wonder whether the real intent of the support for Ebola in the three most affected countries was perhaps more interest in the precious samples that were available. We heard horror stories, and I visited all the three countries, Guinea, Sierra Leone, and Liberia. Stories about whole bodies being carted away by some interested parties for further dissection and research. I'll not mention the guilty parties. I sit on the data access committee for Ebola data, which is based in Edo at Oxford. And I'm trying hard not to mention names lest I get into trouble. Some major countries were still unwilling to share the number of samples that they took from various countries. A few did. I can say the UK did. Some other didn't. Some other. All right. Another third globalization protocol instead of global solutions. What a paradox. And one of the paradoxes which I'll speak to when I conclude is how now countries are, well, the UK, for example, contributed significantly to COVAX, and is the same country also now saying they will explore how they can allow those of us who have been vaccinated via COVAX into their country without any quarantine. Totally unacceptable, but I'll get there. We'll have a little bit of thing to do. So would I argue that we're fairly lucky with Ebola? Like as we were to a large extent. These were the hard-hit countries, as you can see. There were mildly hit countries like Nigeria and Senegal, just eight cases between them, as opposed to, that's 8 deaths, right? As opposed to 11,000 plus deaths in the 3 most affected. And we're all in West Africa, right? And then there was Ghana with no cases at all. I find that pretty amazing. And some people did some modeling and suggested that Ghana was perhaps the country most at risk, and I really think so. The reason is that we have the highest number of migrants from Liberia in Ghana, and so there's a lot of movement between the two. There were flights. Delta was always flying between Freetown and Monrovia and Accra almost on a daily basis. There was also Kenya Airways that was doing that same lap on the West African coast. There were so many flights in and out of Ghana, several options in and out of Ghana. So we're really, there were no cases. Now, I try to press on this argument by showing this table where I have sort of lined up a couple of indices like the HDI, Human Development Index, and a bunch of others, and concluded with the GNI, Gross National Income, and juxtapose this against Ebola deaths. So look at Liberia with 4,810 deaths, and look at the GNI in terms of purchasing power parity per capita, 1,258. Now look at also that for the other countries, Guinea and Sierra Leone, and compare with Nigeria and Ghana. There seems to be some correlation with the level of development. These were the same infrastructures that were available during Ebola and had actually been strengthened on account of Ebola, and yet they collapsed in the face of COVID. It was insufficient, all right? Sufficient, all right? You look at a country like Cuba and look at the GNI, for example, all right, for example, GNI of 8,621, as opposed to the USA 63,000, Germany 55,000, and Japan 42,000. And you juxtapose this against life expectancy, all right, the HDI value, and then the deaths from COVID. And it tells you that being deliberate about your pandemic preparedness efforts and general public health efforts really makes a big difference, because Cuba is not a big country. One would argue it's not a very advanced country. Look at the GNI, and prioritize health in very interesting ways, which reflects on the life expectancy and also reflects on the impact that the pandemic has had on them. Now, moving forward, I like this quote from the existentialist Danish Søren Kierkegaard. And he said, life can only be understood backwards, but it must be lived forward. So it's really important that we take a look back at what we've done so far, try to understand where we're coming from, because it's going to inform what we will do moving. These are the good old days where we're talking about only 1 death. Now at a couple of zeros. I believe we have done well. But there are issues behind the numbers and the interpretation and how they must influence our decision making. I just want to go into this a little bit. I start with the issue of the number of persons infected. So the number of persons infected is always a tricky issue. It is what it is. It's a function of just people being infected and transmission dynamics. But it's an end that you would hardly ever know. You would hardly ever know, because unless people are tested, you never know they were infected. So you sort of draw down that number by testing individuals, and you have a limited number. Now, out of those who are tested, testing individuals, and you have a limited number. Now, out of those who are tested, it's only a set of records for one reason or the other. Validity of your numbers in terms of how far they represent what is going on in the country. There's also the question of cases informing decision making. So ultimately, these cases which you have, which are reported informing decision making, what do they really mean? And we can take a look at what we try to do in Ghana, starting with the school closures, and then the travel ban in Accra, and then in Kumasi. All these are referred to as stopgap measures. And they all ultimately would be needed to be saved, or the day really needed to be saved by the availability of safe and efficacious vaccines, which we never really been presented before. And this reflects how some data which has never really been presented before. And this reflects how what we did in Ghana could be argued to have actually worked and worked fairly well, but also has its limitations. Now, this will be published soon. It was accepted into PLOS 1 last week, so it should be coming out pretty soon. But it just reflects on the y-axis on the left, the proverbial R0, the reproduction number. And you can see how this kept reducing in line with some of the interventions that were made, including the lockdowns and others. So you can see these are the various interventions that we went through. Now, if you juxtapose this against the positivity rate per the Ghana Health Service data, you'd realize that the positivity rate was going up. And this is a function of the numbers of people being tested at the time. So this is just an example of how the number is going low. And this is why we kept on calling for sentinel sites, a systematic approach to sampling and graph, but this time juxtaposing the same reproduction number against just the numbers of cases that we saw, and this is between March cells. So we decided to be a bit innovative about this and use a technique known as the jackknife estimate. The pandemic were fairly accurate because these were in travelers and they were screening everyone. So one could argue that we're catching almost the entire number of people who have been infected. And so this was pretty reliable. So if you use these as a sort of conclude that the positivity rate would actually be an overestimation of the true incidence rate. Because if you use the jackknife estimate, this would have been the trajectory, right? Instead of what we actually see if we use the positivity rate. Now, I'm just proxy, and you project that against the numbers that we had later, you conclude that the positivity rate would actually be an overestimation of the true incidence rate. Because if you use the jackknife estimate, this would have been the trajectory, right? Instead of what we actually see if we use the positivity rate. I'm just showing this to show how it's so critical that we have a system of either testing everyone, well, not possible, but making sure that we're testing representatively enough. Otherwise, you end up with beautiful graphs, nice numbers, but they really are not telling you anything at all to inform your decision making. So really critical that we plan for the unknown future. It is critical that we plan. It cannot be passive, it must be active, it must be deliberate, it must be aggressive. I say this because I want to use the example of that little country, the UK, just as small as us, and some of the amazing things that they did. I think it's a good example. The UK started off on a very bad note with several dead. At the height of the pandemic, close to 1,400 deaths per day, unimaginable. That's more than all the deaths that we've had cumulatively throughout the whole pandemic in Ghana. But the UK was recording some of this on a daily basis. And when they realized that they had made I won't say they made an error, but that their hypothesis had been proven wrong, they quickly turned around, and again, they were being informed by the data, the science, the information. The science at the time was not sufficient for you to say that going for herd immunity strategy would be disastrous. They hedged their bets, and unfortunately they lost. But when they realized that they had lost, they quickly put in place the measures. And now they are among the highest vaccination rates in Europe. The UK reopened fully ahead of many other European countries. And they have a top-tier surveillance structure, which includes sequencing beyond our imagination. They have a health system which is fully plugged into the research infrastructure, which allowed them to run the recovery trial, which is the largest COVID drug trial in the world, being run in that small country, the UK, because the whole NHS is plugged into the research system. I'm glad to say, hopefully, we'll be running a recovery trial in Ghana soon. We're just waiting for the final clearances, but we should be the first African country to run a recovery trial, and it'll be led from KNUST, of course. Or you can clap for that if you would. And so I just want to show some examples of some things that we got right pre-pandemic. One of the first things is the strengthening of the national ambulance system. This was of ambulances for them. This was almost really a blessing. We did not know that COVID was coming, but we're going for a bunch of ambulances. Forget the brouhaha around, where they got them from and how much they cost. That's a different story. But we got a bunch of ambulances. This saved the day. I don't know what we would have done if those ambulances were not present. It would have been a total disaster. So that was our luck number one. Another one also was the building of health facilities. There had been a drive to build more health facilities. The Ghana East Municipal Hospital had been built, not for COVID, but it turned out to become one of the COVID, if not the major COVID hospital within the Ghana Health Service system. All right. So this was a real blessed system. All right. So this was a real blessing. Also, it was built pre-COVID or just before COVID. There's also been an organic growth of training facilities across the country. A lot of students enrolling into medical schools. I dare say too many. I'm sure that my colleagues would agree. It's not very easy these days, teaching and marking. That reminds me of a bunch of scripts to mark. But just the numbers of students entering to the nursing colleges, the physician assistant colleges, all the other colleges, really, really huge numbers. And this also was something that was a blessing in itself. The scientific capacity for R&D, and Gordon rightly pointed out that he had gone for reagents to do sequencing for malaria and had the capacity to do sequencing, which he was able to quickly turn around and use for COVID. This has translated into different things. At KCCR, we had the capacity to do PCR testing. This was quickly ramped up, and KCCR became one of the major testing sites, was visited by the president. We had clinical trial capacity. We had just started building this up. And so currently, I'm really proud to say that at KNUST, I think we have the highest number of COVID clinical trials anywhere in Ghana currently. And that's because of capacity that had been built up pre-COVID. We were able to ramp up really quickly. Also, thinking about the presence of DIMS. So our ability to flaunt our DIMS data is what allowed Ghana to be the first country to receive vaccines under COVAX. All right. So these were all really great pre-pandemic actions that we took. And then the Ghana Drone Delivery Service, another highly contentious issue, which turned out to be a blessing to us in Ghana currently. And that's because of capacity that had been built up pre-COVID. We were able to ramp up really quickly. Also, thinking about the presence of DIMS. So our ability to flaunt our DIMS data is what allowed Ghana to be the first country to receive vaccines under COVAX. All right. So these were all really great pre-pandemic actions that we took. And then the Ghana Drone Delivery Service, another highly contentious issue, which turned out to be a blessing to us. From where I sit in my office in KCCR, I'd always hear the drone flying overhead, and I knew a package was being dropped. So I was able to gauge the intensity of COVID by the number of drops. The more they fly, it's really getting bad. The less they fly, it's getting good. So that's just how it works. But all these pre-pandemic activities were things that really helped us to address COVID. In a way, it was a great stroke of luck, each of these coming together. And then during the pandemic itself, we took a bunch of actions, and I'll go through these really fast because I'm cognizant of time. And also the previous presenters have touched on a lot of these things. The way we handled things at the airport was phenomenal. We got that right. Collaboration with research institutions, and the building of the GIDC by the private sector. It's a beautiful place. We are collaborating with them to run recovery trial. I was actually expecting the director of GIDC here today. Hopefully he'll come tomorrow because they want to learn from us some of our capacity for clinical trials, because they want to start a clinical trial there as well. Then we also had the setting up of the COVID-19 Trust Fund. which is totally independent, giving out support in terms of grants. My group is one of the beneficiaries of that, supporting our seroprevalence work with Tony, who's sitting there, is leading. We have really interesting results on that he presented yesterday. The COVID-19 task force was also brilliant because you need that independent setup, independent from the Ghana Health Service and from the Ministry of Health, to be as nimble as possible to address issues during wartime, because the Ghana Health Service is not traditionally set up to address pandemics. A bunch of other things that we did right. I will try just to touch on a few of them because of time. Our regulatory authorities, and I must say, our regulatory authorities in Ghana are considered among the best in the continent, definitely among the best three, very highly regarded, not only here in Africa, but also in Europe and in North America. And I say there's no flattery at all, because I sat in several meetings where they've made contributions, and you see the soundness and the richness of those contributions that they make to global the contributions of our risk communication from the president himself, the fellow Ghanaians thing, which was really great. A few countries managed to pull such kind of risk communication off like we did. The contributions of the GMA, really stellar contributions of the GMA made. And also scientists, Gordon, myself, Michael, Augustina, several others from here at KNUST. I did a couple of interviews with Science Journal, with Le Monde in Paris, and with The Guardian in the UK. Several international media houses all came for interviews, all on COVID. But that being said, we did a couple of things wrong, and we need to point these out so that we can learn from them. The conspiracy theories and miscommunication by some public figures. We must continue to condemn this and denounce it so that it doesn't happen again. But it was really unfortunate and did not help things at all. The limited access to testing. People wanted to test, but they were not allowed to test. I know Elikem, I know very well that Nyaho really struggled to get their licensing for testing done, and there was a lot of sort of resistance from the government side to allow private entities to test. I know the whole story. I can understand why they will be hesitant, but I think that we could have done that a lot better to allow for voluntary testing. As many as wanted to test should test, because that will give us better information. There's also limited capacity for managing cases, and we saw this in the third wave. If the third wave had continued just by a day or two, our health facilities would have been totally overwhelmed. There was a point at which the premier facilities for treating COVID were just at breaking point. If it had gone on for a day or two more, it would have been a total disaster. And what happens is that when these facilities break, it then spills over, because people who would have normally come to hospital and be contained would now be in their homes in the community, and then leads to an explosion. So we were, excuse me, say, damn lucky at that time. And how many times can we be lucky? We talked about being able to, how many times can we be lucky? Really important that we beef up our capacity. And at some point, we did not practice what we preached. We talked about being able to, bring economies to life, but not people to life. But we did voter registration, we did elections. Well, those two don't kind of meet. But we made our choices, right? We made our choices, right? Okay, these are things we need to talk about and talk about openly. And also limited access to national data in the public domain. And the data made available, and it was not made available, unfortunately. If I tell you how we did that modeling, which I showed you, you'll find it really interesting. We just wanted the Excel file for the numbers which have been put up on the Ghana Health Service website. We never got it. What we did was that we took the picture on the website, and then I had my research assistants, I blew it up high resolution, had them trace the points and plot it in Excel. 3 independent people did this. I controlled for any errors, and we did the modeling. All that pain, when we could have just shared an Excel public domain, so that any researcher can do the best with it and share, anybody and everybody. Steve Jobs said this, and I quote as I try and round up, you can't connect the dots looking forward, you can only connect them looking backward. So you have to trust that somehow the dots will connect in the future. And it's an interesting thought, because I would like to add that it means that you also need to try and place some dots somewhere intelligently, in the hope that in the future they will line up well for you, maybe not as badly as, starting up with a good idea. And some of you saw this on social media. Starting is better than nothing. So we need to intelligently drop some dots so that when we connect it, at least we get a picture that we had anticipated and not surprises. So moving forward, broad strokes, 4 broad strokes of things that we can do. I'd like to touch first on the IT sector. Beefing up our IT sector is non-negotiable. During the pandemic, our IT infrastructure helped us, but it broke at a point because it could not support, apart from parts of Accra and Kumasi where 4G was available but severely constrained, there were massive challenges. And everything now works with an IT backbone. We saw how our own university struggled to get up on our feet with our IT because we had not yet arrived there. But eventually we did get there. We started running courses online and we were able to get up and running. And now of what we need to do. Now I'm talking about anticipated and not surprises. So moving forward, broad strokes, 4 broad strokes of things that we can do. I'd like to touch first on the IT sector. Beefing up our IT sector is non-negotiable. During the pandemic, our IT infrastructure helped us, but it broke at a point because it could not support the number of activities that had moved to the 4G was available, but severely constrained. There were massive challenges. And everything now works with an IT backbone. We saw how our own university struggled to get up on our feet with our IT because we had not yet arrived there. But eventually we did get there. We started running courses online and we were able to get up and running. And now we are not the same. We are much better because we were forced to via IT. Roads and transportation is so critical, an integral part of what we need to do. Now I'm talking about general things that we would do which would beef up the state of the country, not directly health related, but which when pandemics occur will help us to do a much better job. Not to speak of the financing mechanisms, these are definitely things that are necessary. The COVID-19 Trust Fund was set up as an emergency because we realized there were no funding mechanisms to address the needs that we had. And then, aside all these general things, there are specific pandemic preparedness actions that we must take, deliberate actions. Now, this becomes a bit tricky because pandemic preparedness actions are expensive, they need to be maintained ad infinitum, and you may never have a pandemic. So it becomes difficult to keep on doing the same thing over and over and over again, saying one day, trouble will come, so before prepare. But the argument is that you're trying to prevent that problem. So if you're really doing it well, there'll never be a problem. And you've got to justify why you've got to keep on doing it. So it's really a challenge of sort of balancing things like the heavy investment in technology, which is expensive, being futuristic about it, also because technology becomes redundant really fast, and the infrastructure is expensive, and just getting it right so that in the event of a pandemic, you are on a solid footing. Specific things we can do include enhanced and coordinated public education campaigns, particularly around vaccination, and I already demonstrated how we all share different views, even among a sample of a population that where everyone has a university degree. And so just promote the right kind of content via various media and various channels, very critical. We need to address some of the issues that have arisen around the vaccine hesitancy, and these are specific actions that need to be taken. I've listed some of them because of time. I will not go through them one after the other, but there are solutions that we have to make sure that we move this forward. And the evidence is very clear. Raising the proportion of people in the country who have been vaccinated at a critical level is the single major solution to us coming out of COVID, aside Gordon's variant crash, which we can always pray for, and I do pray for that. But aside all this, we also need to make use of actual data, all right? I've posited that if we take our seroprevalence estimates seriously and really measure these well, we could achieve immunity or herd immunity for that matter, much quicker than we think. Initially, estimates were putting our seroprevalence about 20-something%. More recent estimates using ELISA are putting it closer to 40%. We finished Kumasi, 40%. Accra, we are ending next week. It's close to 40% so far. We're going to be doing Tamale very soon. If this is anything to go by, and the presence of antibodies, arguably 4, 6 months, maybe more, 8 months in the body, together with an intense vaccination drive, that suggests that if we're able to even vaccinate 30, 40% of our population, we could achieve herd immunity. But we need to do the math, all right? And if you juxtapose this against also vaccine hesitancy rates, which I showed you, it gives you an idea. It gives you an idea of the kind of effort that you need to make, how you need to target your communication, the kinds of populations you need to address. We really need to make use of the data, and we have more than enough. Look at the amazing data that Gordon presented on the variants. We have so much from the public health angle down to molecular angle. We can make some really solid decisions. Many countries in Africa don't have what we have. We have all it takes. We need to. So this is just a slide from Tony's presentation yesterday on our seroprevalence, and you can see the variation by sex, and the variation by age grouping, and variation by educational level. All these were not segregated, have a higher seroprevalence, they're more educated, as opposed to what is in the media out there, that it's the educated people, the rich people who are getting the disease. In actual fact, it's the opposite way, because we know that it's a paradox, because the more educated, the more knowledgeable, the more likely you are to test and to go to hospital. So you pop up on the radar, whereas the other person who cares less about it will never show up. They'll just die quietly with no notice. We need global policies at different levels, and I'll go through all of these. But the challenge with these global policies, right from response interventions through to elimination or even hazarding eradication options, the world is homogeneous in one way, but also because we know that it's a paradox, because the more educated, the more knowledgeable, the more likely you are to test and to go to hospital. So you pop up on the radar, whereas the other person who cares less about it will never show up. They'll just die quietly with no notice. We need global policies at different levels, and I'll go through all of these. But the challenge with these global policies, right from response interventions through to elimination or even hazarding eradication options, is beleaguered by several paradoxes, and I've been making use of this word paradoxes, because they are really real. The world is homogeneous in one way, but also very heterogeneous, and the same even applies in country. I want to highlight particularly this, a variance in value systems, which make global policies for prediction and prevention a challenge. I cringe when I hear some Western friends talking about, banning the consumption of wildlife and all that kind of stuff. These are people's ways of life that have been handed over generations. Who are you to say that they should no longer, eat wildlife or eat their bats? So it's very difficult, and yet it is true. Some of these things are things that we need to do to be safer. Think about the actions we need to take against climate change. They're talking about banning the use of coal. We don't use coal in Ghana very much, or at all as far as I know. But in places like India, this really is where the poor people get their energy from. Banning it is not an option in India. But how do we balance this to achieve what we need? And what I talked about as I conclude, prevention, and how prevention and prediction are expensive, and we can say some things about them in a very positive way, that if you do this, you prevent pandemics, but there's a lot that we cannot say. Will prevention necessarily lead to savings? It's very difficult to say, because some pandemic actions are very expensive, and they may eventually cost you more. You are compelled to put a price on human life. Well, we say it's priceless, but economists will always put a price tag to it. So at a point, the economists will tell you that this is not cost effective. All right? These are real challenges that we need to confront. But ultimately, there's this big elephant in the room, which I address as my final point, which is the equality and equity conundrum. And unfortunately, many global partners miss this and focus a lot on the equality, and they forget the equity. I remember when we were discussing how to set up this Ebola data access platform. And there were arguments that, look, it's fine, the data can sit on servers in Oxford, and anybody can access it, and blah, blah, blah. And I tried hard to explain to them that, yes, it can sit on servers in Oxford, but how many countries have the skill and the wherewithal to take that data, analyze it, and make decisions? So while you're talking about data sharing, openness, and blah, 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 it is you who have the capacity to exploit. So it's not all about just equality, but real equity. And this argument, I think we need to keep on pressing. And we've seen this clearly with maldistribution vaccines. And I want to reference Jeffrey Rose's prevention paradox again, because it's an interesting concept. It suggests that to really make a difference, you need to focus on that middle part of your population. We always like to think, oh, those who are at highest risks, those who are really down there, we need to focus ultimately on them. But the reality is that to make a big difference, you need to focus more on the middle and shift that whole curve. Because when you shift that whole curve, that to make a big difference, you need to focus more on the middle and shift that whole curve. Because when you shift that whole curve, there will be some, the rich will be richer, but the poor will also be better off. You don't want a situation where the rich keep on getting richer, the poor get poorer. What you want is to allow the rich to get richer, but allow the poor also to get better off. And this is what Jeffrey Rose tried to talk about, decisions that will push everybody up and illness. I'm not going to all these because not necessary right now, but just to also point out that this equity and solidarity issues unfortunately have not been trumpeted enough. I was very proud when our president at the UN was, and more importantly, those of us in academia, to really make much more noise about this inequity. Because if we don't fight it like a canker, it will always come back to bite us, as we've seen in this pandemic. I will skip this and skip this as well, and just go to my last, which just reflects this inequity that we have. A few days ago, the Africa CDC released a strong statement, and I was very fortunate to be part of the drafting of some of these, and we had to be really careful about the drafting of some of these statements because they are sensitive. I mean, the Africa CDC or the Africa Union, which the Africa CDC is under, is financed largely by less, and so really massive complaint about. Because they are sensitive. I mean, the Africa CDC or the Africa Union, which the Africa CDC is under, is financed largely by EU funds, right? So if you want to bash the head of the one that feeds you, you've got to bash properly, but you've got to bash nonetheless. And so really massive complaint about some countries' positioning around accepting vaccinations from Africa or not accepting vaccinations from Africa. And saw the release of the statement from the British High Commission literally on the same day, the usual nice political statements about how we're exploring avenues by which we can see how we can, and the usual things, but really meaning nothing. I'm eager to see how quickly this will really translate into action. You provide vaccines, and yet when the people are vaccinated, it says it's not good enough to come into my country. Just doesn't make any sense. I really can't think about it. So the time to act is really now. Otherwise, we might not be so lucky the next time around. We can prepare, but the evidence is that sometimes, no matter how you prepare, you will still be overwhelmed. And because of that, you cannot afford not to prepare, but you also have to be aware that preparation might end up being insufficient nonetheless. So with that, I'd like to say thank you. And my quote I leave with you is, COVID-19 is the super wicked challenge for the decade, which only a concerted One Health approach, spearheaded by a new multidisciplinary army of One Health professionals, you and me, insights and solutions. So thank you very much for indulging me.
Thank you. Another round of applause for Dr. Mwesi. Almost wrapping up the first session for day 2, I would want to acknowledge sponsors for the 9th Biennial Scientific Conference. Our main sponsors are also Chemist Amponsa Ifa Pharmaceuticals, Vital Pharmacy, Profarm Chemist, Life Chemist, and then the West African Center for Cell Biology of Infectious Diseases. Supporting sponsors are Noda Hotel, LabChem Limited, Parkus Ventures, Aspis Pharmaceutical, Puku Pharma, Solar Biochemist, Danny Praise Computers, and Tradewinds Chemist. At this juncture, I will invite the chairman for the conference for his remarks. Let's welcome Professor Peter Donko.
Thank you very much. Good morning. You all quite glum. Can you stand up from it? Stand up where you are, please. Yeah, stretch. We're going on a break soon. All right, and then you can sit. Thank you very much. This is beautiful. Thank you very much. Good. You needed to stand and stretch. Well, we've had some wonderful presentations. First one by Dr. Amaklo, where he touched on the role of the private sector in the fight against COVID, and the successes they've chalked at Nyaho, and how this can be shared as part of a private and public. And then Professor Awandari told us about the sequencing and I think what really impressed me most was the fact that faced with a challenge, you used reagents meant for malaria sequencing for sequencing the COVID. And that, I think, it's innovative, and that is how scientists are challenged to think on our feet any time. And of course, John has just challenged us as the chairman of the scientific committee. I would like to say that if you don't have any announcement, then we're going to take a break.
So the planning committee has secured these for speakers, and our chairman will do us honors by presenting it to them. We first begin with Dr. Elikem Tamaklo, our very first speaker. Thank you, Dr. Tamaklo. Thank you. I now invite Professor Gordon Awandari to receive his. Thank you, Dr. Tamaklo. Thank you. I now invite Professor Gordon Awandari to receive his. And of course, our last speaker, Dr. Amwesi. We are done with the very first session of day 2 of the 9th Biennial Scientific Conference right here at KNUST. Let's observe the following, please. When the session comes to an end, we'll go straight for our snack break at the basement. Those behind will use the door to my left up there, and those here can descend after this front door. As this, our guest speakers right here on these, the media team would want to interview. So as we have our snacks, but please jot this down. At 1:45 exactly, we'll reconvene here for a very short closing ceremony. The personalities who grace the occasion all the guests who came in from far and near. We thank you. We'll reconvene here at 1:45. We go for snack now, poster viewing, and then the breakout session.